Hello, my name's Emily. I'm the Programme Lead for Community Mental Health Transformation here at CWP, and welcome to our presentation about Community Mental Health Transformation. On the screen now is an overview of the things that we hope to cover in this session. We want you to have an overview of the reason why we're doing community mental health transformation. We want you to understand the clinical evidence base that we're using and have an understanding of the topics that people have told us are important to them. We want you to have time to learn more about our emerging new plans. These plans have been developed over the last 2 years, but we want you to learn more about what's happening right now. And we want you to have the opportunity to share your views and to ask us questions. For most people with mental health needs, getting a diagnosis isn't all they need or want help with. We want people to go beyond their symptoms and their illness. The transformation is looking at integrating services so we can see a person rather than their diagnosis. We want to be able to work together so that we can support people with their all-round well-being. This includes their physical symptoms, where they live, their family, their community, but most importantly, what is important to that individual too.
Hi, my name's Arlo King. I'm going to run you through a few slides about co-producing the mental health framework. So as the transformation involves a range of partners, as you can see on the screen, we're going to try to deliver a fully integrated community model where people will be at the heart of their care, and they can be able to personalize it with accessing a support of ranges for their mental health needs. So as you can see, primary care networks are one of our partners, as well as local councils, voluntary and community sectors, as well as local NHS and integrated care board from Cheshire and Merseyside, as well as obviously people with lived experience like myself. So our ambitions and hopes for the transformation really is that people will be better supported in the community with more help available to reduce the amount of people that end up in a crisis or have a severe deterioration in their mental health. Therefore, we're trying to focus more on prevention rather than deterioration of the mental health of individuals. And when they do have to access further mental health services, knowing that they will be treated with respect and not seen as just another number or their diagnosis, rather than seeing them as an individual. So we're shaping the future with lived experience by co-producing the community transformation. We're putting the service user's perspective into meetings, such as work streams like the core development group and the peer support roles, task and finish group. Two of the many things we've been involved in. Other things such as we've helped co-produce the logo for the transformation. We're helping show how things could work well or not work, and how services can be improved with access and knowledge to community groups, as well as the services for people with mental health, rather than the current system where perhaps people would go straight into secondary care or present in a crisis. The overall aim is to reduce that people go into crisis or secondary care so that people can have a more holistic approach to their mental health journey.
Part of the transformation programme is about communities at care. Embedding the voluntary and third sector is a really important part of our community mental health transformation. Making sure that our community is working with and for people with mental health needs is really important to us. Making sure people have access to support means that we can ensure people have the best opportunity to improve their well-being and quality of life for the long term, not the short term. This includes specialist mental health care, so services such as our complex care service, Services such as our eating disorder service and community rehabilitation. This also includes services which are provided from our local authority partners such as social care, housing support, employment support, debt and financial advice, volunteering opportunities are also really important and make people feel more secure and more involved in their communities. We know that peer support and the support that people with other lived experience is really valuable to people who are in recovery. Community interest activities and being involved in the place where you live helps people feel connected and less socially isolated. And also physical activity. We're really keen to support people's physical well-being as well as their emotional and mental well-being too.
Oh, thanks very much, Emma and Arlo. Just to introduce myself, I'm John Parker. I'm a project manager within the community transformation team, but I've also had the privilege of working in community mental health teams for CWP for a number of years. So it's a real privilege to be involved in this work. And what I just want to briefly talk about is the 4 guiding principles from NHS England around this transformation, and particularly around good mental health care that everybody within our community should access. So the first principle is ensuring that the care is flexible, personalised to reflect the local population. What the team has been looking at as well is very much the local statistics, because again, we've got to reflect that Wirral's needs might be different to Cheshire East, and Cheshire East needs might be different to Cheshire West. So we've got to create services that are flexible and really respond to local need and works with local organisations who can provide that service. The guiding principle number 2 is about making sure that access to our services and all mental health service is improved. It's clear, it's simple, and it's quick to get the support and the interventions when they are most needed. We're very keen that this is about reducing doorways or blockages in the system that prevent people getting the care and input that they need so quickly. Moving on to number 3, we want to remove the need for people to tell their story. One of the things in our earlier public engagement events talked about how clients are forever repeating themselves, telling various organisations, including health, local authority and in the voluntary sector, about having just to say again and again what's happened to them, what they've been through. And in a way, re-traumatizing and having to say that story over and over again. And of course, from a health service point of view, it's very inefficient to sort of have people say their stories constantly. So it's trying to remove that and have this sort of one assessment or one story that follows the person and evolves with them in their journey. And then the final principle is number 4, a holistic approach. Again, we always aspire to provide holistic care, but this is about putting it in a very different way and working within organisations and within a wider community to ensure that the offer of all services is truly holistic and isn't focused on diagnosis. As mentioned before, it's moving away from that. It's trying not to think, yes, a diagnosis can be helpful because it can guide treatment, but it's not the be all and end all. There's a lot of things going on in somebody's life, and the community and the wider community particularly has a place to play in assisting people with that holistic approach. So this again is about, again, reiterating a little bit of it, but this is around the public engagement that we did a while ago and how we engage with the public to find out what is it that they really want. And again, just going through this list here, as you can see, again, it's around holistic person-centered assessments, not repeating things. People wanted a range of interventions, online, one-to-one groups, in very unique and dynamic ways of perhaps giving interventions that perhaps are reflective of people's individual needs. Again, we've got to reflect that one intervention for one group of individuals will not be suitable. For example, a group of 18 to 25-year-old men may need a completely different intervention to a group of 45 to 55-year-old men. So it has to be very unique in a range of things. Very keen to look at patient-initiated follow-up. We're trying to very much move away from the word discharge so that people actually can follow up and initiate their own follow-up with services when they need it and when they feel that things are changing within their mental health. We want to share skills. There's some fabulous skills already going on up and down the community network. And we want to share that so that people then aren't having to wait for some skill in waiting lists and things like that. We want them to be able to get the necessary intervention at the time that they need it, but also then share those skills and abilities within that wider network. For example, can statutory services offer training opportunities to the voluntary sector and vice versa as well? Talking about better awareness as well about what is available locally, really got to this again. I'm bowled away by some of these events as to what fantastic work is going on in the communities already, and what fantastic organisations are doing to support their local populations. Again, they know what's going on in their local communities, and we as other services can really learn from that, and then we can evolve together about what the population really needs. Another big part is, of course, peer support. This is a fabulous opportunity to bring people with lived experience into services and working with us to deliver those services and provide much needed and a different perspective in clients' journeys. We also want to improve the menu of options open to people, and then improve the service accessibility for people with autism. I think that's a very hot topic at times, because we want to make sure that services are inclusive for all, but also specific enough to meet their needs. And then, of course, we're looking at other aspects in terms of the range of support that people are available to. For example, personal budgets. I know that many people have really enjoyed the opportunity to have a personal budget, because it means that they can commission the care and support that they need, perhaps that's not in a more formal context. For example, if it's something that helps somebody to get out of the home, I know that one of our experts by experience is very passionate about using their personal budget for accessing drumming lessons, and that's a fabulous way of doing it, because again, it's about confidence building, learning new skills, etc. And of course, employment support in there as well.
So our voluntary and third sector alliance building is a really, really important part of our development of community mental health transformation, and this is delivered especially by our Rethink mental illness partners. So our Rethink team have been very, very busy developing 3 mental health alliances to support all of Cheshire and Wirral. The team have developed 3 mental health alliances to reflect our place-based delivery, so that we have place-based support that represents our local communities. We know that what's right for Cheshire East won't be right for Cheshire West and Wirral. So we have Cheshire East Mental Health Alliance, which is a partnership with Cheshire East Social Action, Cheshire West, which is a partnership with Cheshire West Voluntary Action, and Wirral, which has been developed by Healthwatch and Rethink, but now has moved over to Wirral CBS. Within each of our mental health alliances, over 30 plus local mental health VCSE organisations have come together with a range of statutory partners, experts by experience, to agree their own terms of reference, and will be working really closely to see how they can support our statutory partners, our communities, to deliver what's needed at local level. They'll have investment through the transformation monies based on the feedback from our engagement events, the insight from our community mental health teams about what's really needed at local level. What's even more exciting is our local authority partners are also keen to use our mental health alliances too. This means our voluntary sector partners won't see money from different pools of money. They'll see it through the mental health alliances. So this is really exciting for the future. It also gives our voluntary and community sector an opportunity to come together, to collaborate, and to work as one system to support local mental health needs. Earlier this year, we also made the investment in some pilot work to do asset-based community grants. We were really fortunate that over 50 organisations were interested in the work, and it was really difficult to determine how we could whittle the list down to something smaller that we could actually fund in year 1. We made £500,000 worth of investment in 14 organisations across Cheshire and Wirral. These organisations have been working for the last 6 months and are ready and willing to support you and your teams. So just let us know.
Thanks very much, Emma. So what we'd like to talk about now is the proposed new community mental health care model. What I want to say is that this is very much a draft. It's still evolving, and there will likely be some sort of regional variation, really, depending on the needs of each area that Cheshire and Wirral covers. So let's just look at first of all the core principles, which is the box to the right hand side, and these are the principles that have gone into this, and we've kind of touched upon them already, but we wanted to make sure that this was a model that could be personalized, could be made specific to each individual and the needs of the person accessing services. We also wanted it to every aspect of this to be co-produced with the local people and experts by the experience. And then we also wanted it to be reflective of all the communities where people live and the services that are already existing within there, and then also about looking to what services need to be available in each community too. We also wanted this to be a model that focuses on partnerships and very much is integrative throughout all levels of service. And we also wanted this to be a model based on equality, in that regardless of race or ethnicity, gender, sexuality or disability, that you should have equal access to all aspects of the service. So to go into a bit more detail, you can see that it is a pyramid. And generally, you can say that the very top of that pyramid, the very point, is the very specialist end of the services. Think more acute care level kind of services where somebody may be admitted. But down underneath that, there is a very solid platform of exceptionally good quality and services that are available to all. What we're trying to move away from the ideas of layers and barriers and ways of it. This is a model where you move up and down the pyramid depending on your need at that very time. And it doesn't matter if you need to go up the pyramid again, you can do. And then if you need to go down it, you do so. But what the key sort of things here is to look at is that there's two, although they're levels in here at the moment, but it's just to sort of look at so that we can explain it a little bit easier. But if you look at the left-hand side of the pyramid, you can see that there's the primary mental health care side, and that's the sort of access to, I suppose, GP level care as is known at the moment. But it would be looking at the very new roles that have been created as well. And we haven't touched upon it too much today, but there's the R's roles, which are being developed in surgeries. Now, these are social prescribers. In some surgeries, they've got paramedics, physiotherapists, but also now increasingly there's mental health practitioners there as well at varying banding. And that's fantastic because it means that people are getting their first interface with mental health services very quickly in their journey. If they go and see the GP can immediately put them in touch with this worker, who then, because of the nature of this new model, that R's worker can then interface with the community mental health team or the traditional community mental health teams and the specialist mental health services, so that there is a bit more free flow of information. We can get some good advice from either side and then hopefully help that person on the right path with their journey. So similarly, if we're looking just at other aspects of the primary mental health care, there's some of the more traditional services that we know in there, IAPT, for example, and supporting those with physical healthcare monitoring and things like that. But as you go up that line, you can see that it becomes a little bit more complex and a bit more specialist in its nature. So you can see there the sort of purpley pink box, which is specialist mental health care, and we want to improve the access to those services, but also improve the quality of what's being asked for there as well. So this is what we're talking about, enhanced diagnosis and formulation, and developing co-produced evidence-based outcome and recovery focused work. There may then also be the specialist psychological interventions, and this is also where some of the other new teams sit as well, like the complex emotional needs service or the mental health intensive support team. And they all interface together. There will also be at that level an expectation perhaps of that managing of people with the more chronic presentation. So people perhaps under the Mental Health Act and community treatment orders or Ministry of Justice orders who do need longer term monitoring. But the very difference here is around, if you look at the right-hand side of the pyramid, is the yellow boxes about practical help and support in the community. And this very much references the community assets and the voluntary sector and all the fantastic things that are open there. Because what we're trying to say here is it doesn't matter what level you might be at in terms of primary or specialist, you still have access to all these fantastic community organisations who will be able to deliver a huge amount of interventions that are going to be so important in people's recovery. What the whole idea is that this pyramid is about working together. All of these organisations working in conjunction with together as a genuine partnership so that we can deliver the services that are most needed. And the idea would be is that specialist mental health services may say, okay, we'll do this bit of the care plan, but actually we would like Change, Grow, Live, a drug and alcohol service. You're going to do this bit. We've got this peer support worker in this provided by this organisation. You're going to do this bit. And then, of course, you might have other services that will be doing that, such as employment or other voluntary services that may be working in that way. And so the idea is very much, as I say, about working together and trying to break down those barriers that stop people progressing through their journey. And again, the idea here is about flexibility. People's needs do change over time, and we want this model to be as flexible as the needs of the population are. So thank you so much.
So that's an overview of our transformation work today. There's so much more to come, and we welcome any questions that you might have. So thank you from me, Emma.
And from me, John.
And from me, Arlo.